This session is best practices in addressing and eradicating stigma. All the speaker bios are found in your program, so I'm not going to read them. I will read everyone's title once they come up. And our first speaker is Deepa Rao, PhD. She is a research assistant professor at the University of Washington. And if you want to come up and get your slides ready. And
thank you for inviting me, and thank you for, I guess, bringing me over all the way from Seattle and persuading me to come talk on the East Coast. It's actually been a great experience. I found this morning's presentations to be quite inspiring and very personal, so I thought I would just start off with a brief description of why I work in stigma reduction. So I actually was born, raised, and trained in Chicago, and I did my postdoctoral fellowship in clinical psychology at the Ruth Rothstein Core Center. I don't know if any of you are from Chicago, but it's a publicly funded clinical center where we see patients with many infectious diseases, but primarily HIV. And I worked as a clinical psychologist in a clinic for youth with HIV. And I've got to say I was particularly struck by the fact that, very rarely did people come to actually see me and participate in my services as a psychotherapist. But even more rare was the presence of a woman in the clinic. Very few women actually chose to utilize treatment, and I tried to hear their voices when we had, support groups and things like that. And many of the women would tell me, it was a stigma that they felt that prevented them from coming in. And so at that point, I decided, I could potentially make a larger mark if on reducing stigma, if I went into research. So I did a research fellowship, and now I'm primarily a researcher. I don't do as much clinical psychotherapy anymore, but it really moves me and motivates my work those years that I spent at Cook County Hospital in Chicago. So, as most of you heard this morning, there are many drastic consequences that follow stigma and the experience of stigma. I tend to think of stigma as kind of originating at the societal level, basically defined by structures within our society and power differentials and that sort of thing that can lead to public stigmas and institutionalized stigmas. But because I'm a clinical psychologist, I'm very, very interested in this level of the individual and what exactly happens when a person experiences a stigma and internalizes it. And much of the research actually tells us that basically you can face multiple stigmas, that if you come from a certain racial ethnic background, if you're a woman, if you have another health condition like a mental illness or diabetes, that could potentially increase the type of stigma that you experience. So you could have a more severe form of internalized stigma. And as we talked a lot about this morning, this internalization of the public stigmas are what prevent people from adequately seeking care and utilizing treatment or taking their medications and that sort of thing. And that's what we see reflected in health disparities. Particularly my work has been with African Americans living with HIV, who tend to have higher mortality rates than other groups when it comes to HIV and outcomes. So I've always been interested in pushing this work to another level. I think that the research field needs to do more evaluation and rigorous evaluation of programs that are out there already that we have to utilize in reducing stigma. Any review paper that you pick up these days will be reviews of stigma reduction interventions that are meant to reduce stigma in the public. But very rarely do you find somebody actually working to help a person living with HIV cope with the stigma that they face. So we've seen on the societal level that you can, work at the policy level, like we talked about this morning. You can work with microfinance programs to empower people to reduce stigma, or you can work through community organizing to reduce stigma at the societal level. And I think many of us in the room are actually doing some of these things, which is very inspiring. At the individual level, there's a complete lack of research papers on what people are doing to help systematically help reduce the stigma that people internalize in order to get them more engaged in care. And so this is where I'm just beginning my work, and I'm going to present a little bit of that initial kind of data here. But how exactly do you reduce internalized stigma? I mean, where do you start? Actually, I ended up working with Patrick Corrigan in Chicago, who has a center on stigma and empowerment. And much of his work is the literature that I look at, because there's not as much in the HIV literature. But he tends to work in mental illness stigma. And what he's noticed is you actually need several things in order to reduce internalized stigma. You know, you can educate and provide and correct misinformation that's out there about HIV, whether it's internalized or not. You can help people develop coping skills in order to combat the stigmas that they face, or adequately navigate the stigmas that they face. But the thing that he mentions, this is an example of an educational campaign, but the thing that he very much puts a lot of weight on is contact with people living with HIV, contact with people who are affected. This kind of key piece of any intervention that humanizes the illness for people. So if it's a person with whatever the stigmatizing condition is, person with mental illness, you know, heart disease, HIV, once you bring people who are affected with those who may be perpetuators of stigma, it humanizes the condition for people. You put a face to the name, and the interaction that can come after that is the core of what reduces stigma. So he has this very interesting paper that's just this year published on what components of the contact need to be there in order to be legitimate. But basically, the contact with a person living with HIV, in our case, must be targeted, local, credible, and continuous. And what I mean by this is that we need to have continuous kind of social support that is targeted for particular people, so culturally appropriate, relevant to people's experience, that sort of thing. And I'll give you an example of kind of how we're working with an intervention in order to do this. I'm going to skip through some of these slides. So you heard a little bit from somebody from the International Center for Research on Women. They have an HIV stigma reduction toolkit out there, and actually showed us a picture of what that toolkit looks like. I first heard of this intervention when I went to the International AIDS Conference in Toronto, and Laura Nyblade was there presenting and giving away copies of this intervention, you know, saying, you know, we can do this, we have the resources to reduce stigma. The one thing that they hadn't done at that point, and I think some people have been doing more and more work in this area, is evaluate the results to see if stigma is actually reduced. So what I decided to do was write a proposal to take the toolkit, adapt it for a US setting, and put it through a fairly rigorous kind of research trial to see if it's effective. So as some of you may or may not know, the toolkit was developed in Africa and has trained trainers globally in use of these materials. But, you know, it needed adapting for an American context. One of the things that is part of the toolkit is a series of kind of scenarios that people can read through and try and understand a stigmatizing situation better and learn from it and discuss. And from Chicago, I now work with a group called ITEC, International Training Education Center for Health, and they have started to produce what they call trigger videos. So these are videos that help to trigger discussion on certain subjects. So I thought to myself, well, we can take some of these scenarios from the ICRW toolkit and make them into video. And videos have this benefit of modeling behavior for people that you can emulate later, or you know, triggering discussion that can be quite active and rich. And you can learn from your peers, if this is done in a group setting, ideas how to cope with certain stigmatizing situations. So with the influences of these two interventions, we developed what we're calling the Unity Workshop. We developed it basically showing African American women living with HIV in Chicago and Seattle materials from the ICRW toolkit. We had focus groups. We showed them also example videos of how we could adapt this intervention. And we asked them about their experiences around stigma, and that actually informed some of the content of the resulting intervention. And they gave us feedback on what exercises as part of the ICRW intervention that they preferred to have addressed in an intervention for them. The women told us that they wanted family and community support issues to be addressed. They wanted to talk about stigma in the health care field, stigma that they feel when they go into a clinic or hospital, trust within social networks, and also misconceptions among members of the Black communities that they were in, and also the multiple stigmas that they faced around racism, particularly, again, within treatment settings. So we took about a year to develop trigger videos and pick the right exercises and modify them for a U.S. context. And then we piloted the intervention this last summer in Seattle. And as you can imagine, I moved from Chicago to Seattle, so had a difficult time finding African-American women living with HIV. But we were able to have about 25 women participate in the intervention. One of them, actually, we had to drop her data because she wasn't seeing the questionnaire properly. Her eyes were having trouble, so 24 African-American women living with HIV. And the women that participated had been diagnosed anywhere from 3 months ago to 25 years ago. So we had quite a range of women that participated in this intervention. And one of the most important parts of this intervention was that it was peer facilitated. So since moving to Seattle, I had partnered with a community-based organization called Babes Network, YWCA, and there's a peer advocate that works there that is very open about her HIV status. She works as a peer counselor, leads a support group. She gives testimonials on a regular basis. So we recruited her to be the facilitator for this particular intervention. And I think that she did a phenomenal job. She was a model for other women in the group to kind of emulate and discuss, what it was like to be out and open about your status versus not. Or, they could share stories. They actually did share stories with each other about how they disclosed and that sort of thing. We started out the group not giving them ground rules for the group, but asking them, what are your expectations for this group? We asked them to define their experiences of stigma. We don't need to give them a technical definition of stigma. Every woman in that group had experienced stigma and knew what it was about and knew how to define it. So we asked them what their definition was. In case anybody had questions, we did have that technical definition there, but there was no need for it. And then we asked them what were some ways in that they coped with stigma, and they shared their experiences with others. People gave examples of, I go to church, or I pray, and I spend time with my kids, that sort of thing was the kind of answers we were hearing about how women cope with stigma. We also did, as I believe Vanessa mentioned earlier, progressive muscle relaxation training. So we had, an hour where we went through a relaxation kind of breathing exercise with the women to help them, cope with potentially stressful situations. And then we had an exercise on understanding assertiveness. And I'll play the video from that where people in the group, the women, would kind of try and understand 3 different ways of basically handling a stigmatizing situation: assertively, passively, or aggressively. And then we had them also role play certain situations. We had them role play and try and understand how to disclose. Someone had asked a question about that this morning. Well, how do you help somebody disclose? I mean, one of the things we did was we showed a scene where a woman disclosed. We had them practice disclosing in the session, and then, we encouraged it, but we didn't push it because, disclosure is a sensitive situation. This is one of our last exercises. This is clearly from the ICRW toolkit. You probably recognize it, Anne, but it's called the web of string exercise. And the women would hold a ball of yarn, say a positive word about themselves, and pass it to a neighbor and pass it along and along until so many positive words were spoken, and there was this web that resulted from the exercise. We asked the women to name this web, and this is where the name for the intervention comes from, Unity Workshop. The women used words like peace. It represented unity, togetherness. I'll play the video at the end. What I want to show you quickly is it was an intervention, but it was also a research study. So we piloted it. We measured stigma immediately before the workshop and then immediately after the workshop. This was a workshop that ran across 2 afternoons. And let's see. So, by the way, because these are my old slides and not my new slides, I did reanalyze the data and actually found even closer to statistical significance. P was 0.054, I believe, but not quite statistically significant. With 24 women, it's hard to see a significant difference between pre and post tests. But very generally, from day 1 till the end of the workshop, day 2, there was a 7-point reduction in stigma scores. And from day 1 to a week later, follow-up, day 8, there was a 5-point reduction in stigma scores. So women told us in this questionnaire data that their experience or internalized stigma, sense of stigma, was reduced. So that's kind of a graphical representation of the scores. What does this tell me? Well, what these results tell me is that we really need to study this with more people, and potentially that would lead to statistically significant results. But it also told me that this intervention has good potential to make an impact at reducing stigma. This is an intervention actually that is can be implemented within the clinic setting. And the next step is for us to do a full-scale randomized clinical trial, and I'm writing a proposal for that as we speak, within the clinic setting, and we're going to follow it more long-term. So we're going to do the intervention and follow women over 2 years and look at the impact on adherence to medications and engagement in care. So this is kind of the next step for us, because I've been doing a little bit of work linking stigma to medication adherence. So let me play one of the trigger videos, because I have to tell you, this was probably the most engaging part of the workshop. The women love them. As soon as I played a video in the workshop, all of the women would talk at once. It was very hard to have any control of the discussion or anything like that. They were just so excited about these videos. They were so personal. They very much came from the experiences and the voices that I heard of the women in the focus groups. We developed the scripts based on their information. So, but I'll stay for a few questions and touch on.
Let's take a question now, because she's one of the people that needs to leave early. So if you have a question, please stand to the mic or go to the mic. Any questions?
Hi, I was just wondering if you, I think it's really important that these sessions specifically focus on the women themselves, but I was wondering if in the focus groups, women at all discussed the interactions that they have to face in their families and in their communities, and if there's any thought towards maybe expanding the intervention to sort of also address some of these other groups that could be supportive or not so supportive of the women. Thanks.
We do address family issues. So one of the videos that I didn't play, actually, so you heard many people this morning, and this always strikes me as, when I hear it, as unusual, but then I hear it all the time, is this issue of people at home whose parents force them to use different cutlery, plates, that sort of thing, because they are open about their HIV status and they're kept separate. So we actually have a video where a woman who's living with HIV is talking with her counselor about how her mother forces her to use separate plates, knives, and utensils and that sort of thing. And they just, it's meant to trigger discussion about what are your options. And then during the discussion period, it can come up or be suggested by the peer advocate different ways of coping with stigma in the family. So you heard Vanessa talking about family counseling, something that we would encourage, and or bringing family members in for counseling, your counseling session, that sort of thing. But we didn't have a piece of it that was for families necessarily. We did have lists of support groups and support networks, and we had, the facilitator was had a regular support group going at one of the CBOs, so we encouraged people to go to that. And some of them did connect with it afterwards. Really interesting thing, too, I must say, is the key, like I said, is contact, but this thing that goes hand in hand with contact is social support. It's really fascinating to me. The women came in 1 week later after we did this workshop, and they're trading phone numbers. And they're, wanting to sustain this. Many women said, when's the next one? When can we come again? So, I'm doing, we've got this in a workshop setting to be kind of cost efficient and, done in a short time period. But if clinics can do something like this on a regular basis, that's really what the women want. And just want to mention also, we did focus groups with men as well, and ran the HIV stigma toolkit exercises by them as well. And we found these really interesting kind of stark contrasts that many of the men had trouble kind of even coming to the focus group and talking in front of other men. These were African American men living with HIV. And they told us that they wanted an internet-based intervention instead. So we thought, this could be the next step, that for people who are not quite yet ready for a group intervention, we can go to the internet, put some of these videos online, and do some exercises that way, and then ultimately, encourage them to come to a group and have face-to-face social support.
Next coming to the stage is Rhea Van Brocklin. She is the executive director of the AIDS Project in Central Iowa. Welcome.
Good afternoon, everyone. Thank you so much for having me here today. It's an honor and a privilege to be able to present our state's HIV anti-stigma campaign, which is the first of its kind in the state of Iowa. And I don't know how many of you know even where Iowa is. It's in the middle of the country. We're a very rural community, and I'm just extremely proud to chair a dedicated group of individuals that make up the Iowa HIV Anti-Stigma Alliance, that we were able to even pull something like this off. So thank you for having me here today. So again, we're going to talk about the definition of stigma, that it really is a process of devaluating people either living with or associated with HIV/AIDS. It's labeling individuals, linking them to negative stereotypes. It's an us versus them mentality. Discrimination is only a part of it, and it also affects the dominant group's political access, leading to full rejection of the weaker group. A lot of individuals talked about HIV criminalization this morning, and I don't know if many of you know, but Iowa has one of the strictest HIV criminalization laws in the country. You can get up to 25 years and be classified as a sex offender for the remainder of your life. And this is something that is the ultimate culmination of what HIV stigma looks like. The trend in naming HIV/AIDS as the most urgent health problem for the U.S. and the world obviously has gone down over the past several decades. In 1995, 44% of the U.S. identified HIV as the most urgent health problem, but now, in 2011, only 7% of the general population sees it as that. And this trend is similar also from a global perspective, not just in the U.S. And keep in mind, too, that infections are remaining steady. They're not declining. Luckily, they're not getting bigger, but they're not getting any better as well. So it's important to keep HIV in the forefront of our minds. So you might be wondering why I have hairstyles on this slide, and I have to thank my colleague from the Nebraska AIDS Project, Jordan Del Mundo, for loaning me this slide. But I think when we talk about HIV stigma, a lot of this stems from social norms that the community has. Social norms are a lot like hairstyles. They come and go with the ages, so you can have a feathered hairstyle all the way to Jennifer Aniston. And HIV is different in some aspect because these social norms have not changed. The way that we view HIV in the general population still holds a lot of fear in the minds of individuals. So we think when we talk about HIV with people who don't work in this field, of injection drug users, of gay men, that we should fear those living with HIV. But in reality, we're all either affected or infected by the disease, correct? So why an HIV Anti-Stigma Alliance in Iowa? Like it was mentioned earlier, stigma impacts a person's ability to get tested for HIV, to disclose one's HIV status, seek medical treatment, get a job, get housing, sustain a support system, have a partner, be a good parent, So there are many reasons why this issue needs to be addressed. And in 2009, that was really the birth of our committee. But it stemmed from a couple of assessments that Iowa did prior to us forming this committee. In 2005, a client satisfaction survey, or a consumer needs assessment, interviewed people living with HIV across the state of Iowa, and these were the results. It was done by the Barbara Berger HIV Stigma Scale. Females reported slightly higher total stigma scores than males, minorities more than whites, specifically those who weren't represented so much in the state, such as American Indian or Alaskan Native, Asians, and it's because they don't see a lot of the faces of their people in the state of Iowa. Hispanics scored higher than blacks, who only scored slightly higher than white non-Hispanic persons. And then obviously, since Iowa is such a rural state, people don't have a lot of access to services, so rural clients reported slightly more stigma than urban clients. Homelessness continues to be pervasive and definitely culminates in a form of stigma, and it does show up on this scale. In 2009, at our annual Wellness Summit, which is a retreat for people living with HIV, the clients who attended this summit also conducted their own anti-stigma campaign and a scale. And so what they asked each other was, how do you feel about living with HIV? And these were their answers. So people with HIV, they feel, are treated like outcasts. They lose their jobs. They feel they are dirty. And that one really breaks my heart, to be feeling like you're a dirty person because you have a disease. Disclosure is a hard thing to do, and most people, they feel are uncomfortable around them. They don't want to get close to people because they have this internalized stigma that people are going to feel uncomfortable being around them. So we recognize that this was enough of a problem in Iowa, and I have to tell you, I think when we talk about HIV anti-stigma campaigns, the main reason why there's not enough of these going around is because there's no funding. There's no funding to do this kind of work, and it really does stem from commitment and passion from those communities to be able to address this issue. We were fortunate enough, our state's HIV community planning group is very active, and we decided to go ahead and just start one. My agency, the AIDS Project of Central Iowa, had a very rare occurrence that year where we had enough money to actually work on this campaign, and that was the start of it. We formed, these were the members of our initial group. I have some colleagues from Iowa who actually sit on the Alliance from Siouxland Community Health Center, and we're continuing to meet on a regular basis to address this issue in Iowa. So our mission is to develop effective solutions to barriers and inequities that prevent Iowans impacted by HIV stigma from participating fully and equally in all aspects of life. We hope to eliminate HIV stigma in Iowa, and our tagline really is the tagline of HIV won't stop me. And as I show these campaigns, or some of the images from our campaign, you'll get to know that people embrace this tagline wholeheartedly, whether they were HIV positive or HIV negative. We wanted to form multidisciplinary collaborations, so we have people from the faith community, from marketing companies, from mental health organizations, as well as AIDS service organizations and governmental public health organizations that sit on the Alliance. And we also wanted to develop a statewide marketing campaign that raises awareness in the general population. So there's a lot of talk about doing HIV anti-stigma work with people living with HIV, but we also wanted to extend that to the general population because that's where we all live. We wanted to stimulate conversations both in the rural and metro areas of Iowa and create a campaign that can be replicated not just in our state, but in other parts of the country. And we were successful in doing this because Nebraska, incidentally, adopted our campaign to do one very similar in their state. So with this money, that was a one-time shot at the AIDS Project of Central Iowa, we purchased some billboards. We were very lucky to work with media partners that gave us some free spots on TV. So we created public service announcements. We purchased some print ads in local newspapers, as well as ran a lot of different websites, our main one being IowaHIValliance.com. So the individuals who are seen in this campaign I just want to say, many of them are living with HIV, many of them are not as well. This gentleman to the left is our state senator, Matt McCoy. He is openly out, openly gay in the Senate, and is one of the biggest champions in our state for ADAP funding, as well as repealing the HIV criminal transmission law. The children in the middle are children who, they're not HIV positive, but one of them is my daughter. I liked it. They're cute. Right? And then the gentleman to the right with the silvery hair, he's our mayor. So I was very glad to see Mayor Ford here, because I do feel that it is absolutely important to get your government officials involved, especially if you want to implement a campaign that makes an impact in your community. And all of the taglines that you see, so HIV won't stop me from making a new friend, it won't stop me from making this a better Des Moines, these were taglines that were created by our campaign spokespeople. So they did mean something to them. That was really our first tier, was to create a marketing program that people could follow and talk about. And the second tier was to kind of move outward to the community and get them involved. So we conducted a survey with the general population to raise awareness about HIV stigma in our communities. These were done throughout the state of Iowa, in Des Moines, in Sioux City, in Waterloo, and then also near Omaha, Nebraska, just to get an idea of where people are at in terms of what they feel is most stigmatized with regard to HIV. And it was also an opportunity to recruit individuals to the campaign. What this survey showed us was that HIV stigma is still closely associated with the most basic needs that human beings have. They worry about where they get their basic survival needs, so food. People get worried about people living with HIV serving them food. They worry about having to care for someone who's living with HIV and being married to them and watching that what they feel is a slow-term degeneration of that person getting ill and having to take care of them. Also allowing one's child to play with an HIV-positive child. These were the most stigmatized. But then what we also learned is our community is in the middle. There's not people in the community who, well, there's always going to be people who feel very strongly one way or another, who are totally against HIV stigma and who you will not say anything to change their mind, right? But the majority of our population is really in that middle. And this was the goal of our community, is to move that middle and help them to get more information, so there's not just this ongoing fear about HIV, or even people living with HIV. So this is our third tier of the campaign, that we're really wanting to move the middle, and we're going to do this by encouraging cultural norms that support people living with HIV. How we're going to do this is, well, we've already started, that we are surveying the middle for ideas on effective messaging and marketing strategies. So what's going to work best, and who are the messengers that are wanting to give them these messages. We also did an empowerment training for people living with HIV to tell their stories. And then we're recruiting people from the middle to participate in the campaign. And some other things that we're going to do regionally, Iowa, Nebraska, and also some folks from Chicago and Milwaukee are interested in coming together to be able to do a more regional campaign. So some of the lessons that we've really learned as a result of this is that it's important to involve community leaders, people living with HIV/AIDS, and legislators from the start to obtain community buy-in. We also need to maximize collaborations to share resources and to expand the reach of the campaign. So you can't do it all by yourself. You can't. It's hard to do. And then researching the needs of our community with regard to the messaging that you do and the types of efforts and activities that you do in the community. That coming from the population itself is so important, because it's a waste of resources to try and do this without surveying your community first. So thank you very much. There's my contact information. I know, my cab's out. Sorry, my cab is outside. I wish I could answer some questions, but feel free to email me or visit our website. I'll leave some cards with Lisa. That way, if you have any specific questions, feel free to contact me at any time. Thank you.
Thank you. Thank you for coming. We all know how DC traffic is, so we understand. So next coming to the stage, it's a good friend sometimes. See how you missed that? I was making a joke and you missed. It's Terrence Moore from the National Alliance of State and Territorial AIDS Directors, all these acronyms, NASDAD for short. Please come to the stage. Welcome.
So Lisa's like my big sister, so I heard what she was saying, but I ignored her. That's what little brothers do. So I actually want to thank the organizers of this event, Dr. Rana and Dr. Vargas Jackson and Lisa and all who have pulled this together. I've done many meetings in the past, and I know how extraordinarily difficult it is with all the moving parts to pull this together with speakers and travel, etc. So I'd like to actually give a round of applause to the organizers for doing this today. So actually, if I had to do this all over again, I probably should have gone first, because I believe my colleagues actually gave some really good examples on the ground that are very concrete about the things that can be done across the country and in communities to reduce stigma. And so I'm going to give a much more kind of higher level from a NASDAQ perspective of the things that we're working on and things that we can be doing to eradicate stigma in our communities. Before I go there, I want to talk a little bit about, from a personal perspective, that Howard actually is home for me. This is my alma mater, so how many other Howard students do we have in the audience? And so, yes, I was here before you could register for classes online, when this very room kind of gives me PTSD, because there used to be a line all the way around the yard to register. Lots of tears, but we persevered. But that said, and jokingly, I do want to say that Howard actually really molded me into the person I am today, in terms of both professionally, but I think more importantly, personally, and connecting those experiences that I gathered here into the work that I do today is something that is a part of me. So I want to talk a little bit about who is NASDAD, because Lisa gave this big acronym. The long or the short is NASDAD actually represents state health department HIV/AIDS programs. And so there is in every 50 states and the U.S. territories an office that manages and implements state-based HIV/AIDS programs, both prevention programs as well as care and treatment programs. And so that's NASDAD. So I'm going to talk a little bit about defining stigma, and I know we've done that throughout the course of the day, but for the purposes of this talk, I want to talk about what stigma means to our organization and the work that we're doing. Talk about a project that we're working on related to assessing stigma in public health practice across the country. Talk a little bit, and since my colleagues gave examples, I'm going to skip forward to some top-line areas of how to address stigma, and then of course we'll do some questions and answer. And so I think first on to defining stigma. And so there is much literature out there. I don't need to regurgitate much of what you've heard, but I think there are a couple particular places I wanted to zero in on, specifically about the terminology of stigma. And so while this presentation is going to be focused on HIV-related stigma, I also wanted to make sure I put into or braided the fact that the co-occurring HIV discrimination that results from stigma is equally important. And so we need to be focused in on that and really realize that there is a range of how individuals in our society respond to stigma. For some of us, it's just annoying, right? And for some of us, it can be extraordinarily toxic and life-altering. And so I think it's important for us to realize that individuals manage this in very different ways based on where they are in their lives and their ability to be able to grapple with and work through their events. So Herrick et al. Identifies HIV stigma as related to an overall attitude directed at people living with or perceived to be living with HIV/AIDS and those whom they associate with. So I'm going to talk about the 4 types of stigma that I'd like to zero in on. I think first, personalized stigma, which obviously refers to perceived consequences of others knowing one's HIV/AIDS status. Disclosure concerns, and I'll actually come back to that last. Negative self-image expresses feelings of shame or guilt related to one's HIV status. And then concerns with public attitudes. And so that refers to what most people think about a person with HIV. But I do want to go back to disclosure concerns, and this relates to who one has told about their HIV status and the act of telling others, of course. And so generally speaking, disclosure concerns, at least for me, I believe that's the crux of where we need to be focusing our attention in our society and in our epidemic. I think in order to make and mount a robust response to HIV, we have to transition into an age and an era where people are comfortable talking about their HIV status and disclosing their HIV status. And we have to make it okay for folks to be able to do that without fear of isolation and retribution. And so I'd like to say that for me, this is one of the most important places I'd like to see us focusing on. So in terms of the layers of stigma, I would be remiss to not say that HIV stigma is not in a vacuum. It's not the only thing folks are dealing with. My colleagues have already discussed this, and I'm sure colleagues this morning as well. But we're all complex people, and we deal with a range of different issues throughout our life course. HIV might be just one of those issues. And so the layers of stigma are braided together and oftentimes difficult to decouple. So whether we're dealing with our gender performance, or if we're a gay man dealing with being masculine or feminine, obviously the issues of age, and then we can't renounce the fact that race and ethnicity and racism and what individuals deal with related to that is also important. And so these are the list of things that I think represent kind of a myriad of things folks are dealing with, and obviously this list could go on and on and on. So I want to talk a little bit about my organization's work. It's a joint effort with the National Coalition of STD Directors, a sister organization of NASDAD. And we were actually awarded funding from the MAC/AIDS Fund to do work around stigma and stigma reduction, and doing stigma reduction specifically in public health practice. And so our members are the bureaucrats that sit in states that implement programs that are not isolated from all the isms and issues that we ourselves deal with as just everyday folks. And so we felt that the implementers of programs have to be able to at first acknowledge the issues that they may bring to the table when they're meeting with and working with constituents and designing programs, and then be able to kind of work through those issues in order to mount an effective response. And so our proposal, we really do believe, seeks to mount the first of its kind. It's fairly unprecedented, aggressive, and targeted, working across the 2 silos of HIV and STDs to both examine the issues and then provide recommendations and address them. So again, I think there's a variety of different approaches that are part of this overall grant. I think 4 elements in particular. First being a stigma assessment. and taking a look at how stigma is, the different types of stigma that's happening in communities, looking at social networks and establishing and promoting evidence-based practices and tools for individuals in public health practice to utilize. And so these are some of the things that our members will be working on in terms of this project, but I do want to zero in on the first one, which is the institutional and community level stigma assessment that we'll be launching shortly. So the stigma assessment. So the goal is to assess and survey all of the state health departments across the country, all the 50 health departments, as well as the U.S. territories, particularly Puerto Rico, and I'm talking specifically about Puerto Rico because the scope of this project is to take a look at stigma and stigma experienced by Black gay men and Latino gay men in the United States, and those who do not otherwise identify as gay men and other men who have sex with men. And so the goals of this particular survey are focused on 4 categories: HIV/AIDS and HIV/AIDS related stigma, same-sex sexuality or homophobia, and again, what do communities believe about individuals who are gay? And then gender performance and femininity. And this is one of those third rail issues that folks get very uncomfortable talking about. So sexual positions, for example, and those types of issues. How do we begin to have those discussions? And then once we have those discussions, I think, and this is coming from a gay man, what are the stigmas that we as gay men carry with us about other gay men? And so really trying to access those attitudes, knowledge, and beliefs. And then I think also race and racism. We really felt that given the 2 populations, both Black and Latino gay men, that we needed to spend some time talking about the role of racism and what it can and continues to do on the lives and the psyches of both Black and Latino gay men in the country. And so here's some of the preliminary survey findings, but I wanted to give you a little bit of context. So we had 56 individuals fill out this survey as part of a pilot that we just completed for the months of October and November of this year. And the full survey is going to be released nationwide next week, and the hope is to collect between somewhere of 1,700 and 2,000 responses. And so in the history of our organization, which is 20 years, this will be the largest data set that we'll have ever collected. And so I wanted to provide a few notable snapshots of the preliminary findings. I think first, when asked, Black and Latino health providers are gay-friendly in my community. 20% of individuals asked this question either agreed or strongly disagreed. In my community, most people believe that HIV-positive persons do not disclose their HIV status to their sex partner. 40% either agreed or disagreed. And so we felt that this was particularly disturbing finding, and it underscores an age-old issue that we deal with as we're combating stigma in this country as it relates to HIV-positive individuals and or this notion that HIV-positive individuals are vectors of disease seeking to infect other individuals in society. So this is something we really need to pay attention to. And in my community, fear of others finding out that they are HIV positive stops many gay men and other men who have sex with men from getting HIV treatment and care, 42% saying that. And again, in a world where we have a new national HIV/AIDS strategy and we're seeking to link more people into care and treatment, we do know that this is a huge barrier to being able to do that effectively. And then finally, most people believe that risky behaviors among gay men and or MSM are to blame for there being so much HIV in my community. Again, a disturbing finding. A few other notable findings. When asked whether people in my community believe that undocumented immigrants should have access to publicly available STD and HIV testing and treatment programs, it was a split. 20% felt or strongly agree or disagreed, and 18% strongly disagreed strongly disagreed or strongly disagreed. And so again, I think there's a dichotomy, particularly now in an age of immigration reform, as to whether or not this is an appropriate role for public health. When asked, most people in my community do not think that homosexuality should be included in sexual education classes taught within public schools. 40% of the individuals responded that they agree with this assessment. And so this is important because we know that the way to turn the tide in the epidemic is to begin having these discussions with our youth early. The earlier, the better. And there appears to be disagreement as to whether or not this is an appropriate approach to reaching the youth population in the U.S. and normalizing LGBTQ individuals. And then finally, I'll skip past the next one, community-based organizations whose missions are focused on the health of Black and Latino communities are capable of providing services to Black and Latino gay men, MSM. And their individuals either agreed and strongly disagreed. And one of the things of particular note there is the shrinking resources that are occurring now in our country, and there being less resources from year after year towards indigenous organizations serving these individuals. So I'd like to provide a few top-line ways to address stigma. I think the first is working with clinicians. And Dr. Vargas Jackson and I have had this conversation before, and we really do believe that working with clients to ensure that they're aware that they too can press and ask questions, and that they too can have ownership over their own health and well-being is important. And I say this with a caveat. I am very much so aware of the fact that marginalized populations in this country don't feel like this is their role, and they don't feel like they can ask these questions. And so I challenge us, for the providers in the room and those who work with providers and serve in communities, to figure out mechanisms and modalities to ensure that people feel comfortable talking about their health with their providers, and encouraging clients to express themselves and knowing that they matter. And then I think engage providers and work with your community providers to enhance their experience with working with HIV. Many providers obviously have expertise in a range of other areas, primary care areas, but feel less comfortable in this area. And so what are ways we can do, and what are ways we can work collectively to educate each other, bilateral education. And partnerships with local universities or colleges. I'd be remiss being here at Howard on this stage if I didn't talk about that. I think that college is a time of enlightenment. It's a place where we learn new things when we get to engage on a campus with folks from different places from around the world, from geography, parts of the country. And I think that this is a place where we can challenge ourselves. And I'd like to challenge everybody in this room. I can recall growing up and having relatives make, derogatory, I'm sure I'm not the only one in this room, derogatory comments about gay men or derogatory comments about women. And I think it's high time that we start to challenge the status quo and not be afraid and start to call some of that out. And cultural competency in general, considering sensitive approaches for all clients. It's not one size fits all. What works for folks? Who are the best messengers of information? I think we really need to be thinking about that. My doctor happens to be a gay white man who I feel completely comfortable with. Maybe not everybody's comfortable with a gay white man as their doctor, but whoever you're comfortable with, you should continue to seek out the person that works for you. And I think we should be telling our clients the same thing. And then advocating for peer education via community outreach. We all know that many folks of color are particularly connected to their religious institutions, and so I think we still have work to do in that arena and getting folks prepared and comfortable with having some of these broader discussions about HIV and HIV-related stigma. And so before I transition to questions and answers, I wanted to share with folks a body of work, a few quotes from a body of work that NASA has been collecting over the last few years. We've been working with and doing focus groups around the country with both Black gay men and also Latino gay men, and really trying to understand the lives of both of these communities and their health concerns and their desires. And I just want to leave you with some sobering quotes that resonate with me on the day-to-day basis and continue to help me drive and continue to do the work that I'm doing. So one of these quotes was shared by a participant in a study that we did, and this is what he said. So basically, in terms of HIV for Black gay men, it's not, and this is the punchline, it's not a question of them of knowing how to save their lives. It's a question of them knowing if their lives are worth saving. A second participant said, because I think one of the core issues is self-value, that we are struggling with deep-seated internalizations of a whole range of oppressions that converge. It's internalization of racism, internalization of homophobia, internalization of misogyny. All these things converge in you, and then seeing how the epidemic, the stigmatization of it, that is, the prevention and treatment, then gets internalized as well. That said, I'll leave you with one final quote, which I think is a glimmer of hope. I say, and this is someone talking who is a provider, to this young Black gay man, you are worth something. I need you here next year. I need you here in 5 years. Protect yourself, you know. So I didn't say, here, wear a condom. I said, I need you here, and if you test positive, I'm going to lose you. Very often we don't do that kind of work. You are worth something because out there the rest of the world is saying, no, you're not worth anything. You're not part of us. And I'm saying, no, you need to be here. You owe me that. You see, what I'm saying, and he got it, he got it. I bet that anytime he's doing whatever he's doing, he's thinking about it. I know that. And so I stopped there, and I hope that we can all continue to do the work to really erase stigma in this country. And I appreciate all the work everyone is doing here in this room to move forward in the movement. Thank you. Was there any questions from the audience?
We just heard from Ria and Depa about examples that they were working on. Do you know of any stigma projects just for Black and Latino gay men?
Sadly, no. I know of very few kind of large-scale stigma projects out there, and I defer to a lot of the experts in the audience. I do know that there are a fair amount of new things coming down the horizon that are focused on treatment adherence. And CDC is poised to release diffusion of effective behavioral intervention, treatment adherence strategy next year, but sadly, no. I think it's interesting that we're often comfortable talking about the disparities in terms of HIV on particular populations, but there's very few activities happening as part of the body of work for these populations.
And then my next question, Kali was here earlier, and he spoke about, he was talking about stigma, and he started off with, being gay. A lot of people are first dealing with that stigma, and then you get hit with HIV. So, even when you're doing your study, how do you differ between, these, it's just about all stigma, about, first being comfortable with your sexual identity as opposed to, the illness that you're living with? Mm-hmm. It seems very kind of complicated.
Well, and I think that goes back to the slide from earlier that I put up. I think we're all dealing with a bunch of different stuff, and it depends on what day, what surfaces more. Interestingly enough, and I didn't mention this, and I almost feel like it's my responsibility in every talk to tell the audience I'm HIV positive. And I have been for 10 years. And interestingly enough, the thing that I've struggled with less has been my HIV positive status. I think the thing that has been the most difficult in my journey has been the piece around my sexuality. coming from a religious family. And I think folks in my family have come around, but I think we have to really think about these kind of co-occurring things and how people handle them. So, yeah.
Could you give me that first quote one more time?
The first quote. So basically, in terms of HIV for black gay men, it's not, and this is the punchline, it's not a question of them not knowing how to save their lives. It's a question of them knowing if their lives are worth saving.
Hello, I really don't have a question, but I have a comment. Somehow I am, thinking about what again needs to be done to help rid the stigma. Every year, let's say December 1st, you have this conference, and you hear what different organizations are doing. But after we leave here today on December 1st, very seldom you hear much about what is happening to rid stigma. I think there should be some type of a drive where organizations, faith-based organizations, can get together and make this thing as open and powerful as possible. It must be out there, blast it, because I think people get very complacent after they leave and realize, yes, well, we know of HIV and AIDS, but this thing has to be on the forefront. It's not going away, and we need to work diligently as a unified force to get this out there. You hear things about cancer, the AIDS race, and different things, but education. We need to work diligently and more cooperatively to get the stigmatization of AIDS to be eradicated on the face of the earth.
And I would just respond by saying I completely agree with you, and this is no easy task, but I will say that the work of this conference and conference organizers has been an amazing first step, and I will say, is this the second conference? Last year, I sat in this conference in Crampton Auditorium, and that conference and participating in that conference was the genesis for my organization working on this MAC project and stigma in public health practice. So I think the more we can get the word out and the more that we can get people thinking about what they can be doing based on where they sit, and we sit in all different places across the country, I think that is the beginning to doing more on this issue. Thanks.
Sorry, that is a very interesting presentation, very interesting survey. I see that it's going to be completed by the end of January, right?
Yes.
Would this questionnaire be available to anybody, or?
Yes, thank you. Thanks for the plug. And I did not grab her out of the audience and ask her to ask that question.
I didn't even know him.
And my colleagues in the back of the room from NASDAQ Republic, I cannot believe you didn't say this. So we're launching this survey next week. It's going online. It's literally going to the entire country. And we're really wanting, hopefully, everybody in this room to fill the survey out. So what I can do is, if you want, I can take your names if you want to write your names, and I can make sure we email the survey to everyone that leaves their email address.
Yeah. When you said it will be going to the whole country, I mean, what do you mean by that? How will it be distributed? Can I participate? All these are
It's a U.S.-based, the first round in our work is U.S.-based, so it is specifically around addressing public health practice in the United States.
Oh, I'm here, I'm in DC-based. But so who would have access to do this survey? That's my question.
Everybody, community providers, hospitals, doctors, public health departments, community-based organizations, those who are served by community-based organizations, everyone. We want Joe and Jane Citizen to fill this out as well, everyone.
Okay, thank you. I'll give you my email address.
Okay, excellent, thank you. Thank you.
Thank you. And we saved the best for last. Okay, we have Dr. Massine. He's a regional advisor and works for the Pan American Health Organizations, part of the World Health Organizations. Thank you. Welcome.
Good afternoon. I'm delighted to be here, deeply honored, at the same time deeply challenged after those wonderful presentations and many things that have been said during the day. It's going to be tremendously difficult for me not to be repetitive, not to be boring sometimes because of the reiteration of some ideas that have been stated over and over. So to avoid that, let me use some stories once in a while to make the presentation more sparkling. And I'm going to start by commenting to you that my organization, the Pan American Health Organization, which is also the regional office of the World Health Organization, has, among other responsibilities, the collection and collation of epidemiological data from all over the world, and in particular from the region of the Americas in the case of us here in Washington, D.C. So, we know a lot about some features of the AIDS epidemic. We know, for example, that in the Western Hemisphere, it is estimated that about 3 million people are living with HIV at present time, that about 50% of them live here in North America, and 45% in Latin America, 8% in the Caribbean. Things that you can see on the screen, factual information. But we also know that the epidemic has many facets, many different dimensions that it's important to consider. One of them is stigma, how stigma relates to all these figures we are looking at, and how it contributes to fuel the growth of the epidemic and the severity, the impact of the epidemic on groups, populations, and individuals. Stigma, as it has been mentioned several times, is a social phenomenon that is based on ignorance and fear. Those are two distinctive traits. People fear something about others, usually members of a minority, because they ignore the reality, the humanness of those individuals who make part of minorities. Then they ascribe to them a series of features called stereotypes. Bear this in mind. Fear, ignorance, stereotypes, which are loosely based or not at all on reality, but not always the characteristics we ascribe to a minority are real. They can be a figment of the imagination of the majority who fears something about the minorities. Am I making sense? The following element is a devaluation. We devaluate the groups that we ascribe with a series of characteristics that are fearful and are based on our ignorance. And this devaluation leads the individuals of the group to feel demeaned. We impact their self-esteem. And the last effect is the dehumanization. We take away the humanness of those individuals and make them an easy target for abuse, violence, discrimination, and even homicide. When we see something which is not human, we can easily cause damage to that. Think about turkey chick. If you give a name to the turkey chick, let us say you call the turkey chick Thomas, it's very unlikely that for the next Thanksgiving you will have dinner on Thomas. because Thomas has a very human feature that we have given to that little cheek. And that's true. Well, when we devoid of humanness some individual or some group, it's easier that we commit abuses with them. Bear in mind what happened during the colonial period in Latin America, for instance, when the conquerors, the conquistadores, wondered if Aborigines had a soul or not. If they had a soul, they were humans, therefore they could not be abused. So sometimes taking away humanness facilitates abuse, as I said before, discrimination, and even homicide. When we talk about the populations that are the epicenter of the epidemics, and now I'm going to talk in plural, the epidemic of HIV, the epidemic of stigma and discrimination, the epidemic of marginalization and mistreatment, not all the populations are equally affected. So it's a misleading notion to say all of us have the same risk and vulnerability. It's not true. Men, for example, in Latin America and North America, still have higher rates of infection. And when we look at some specific male populations, like transgender and men who have sex with men, we notice that they have been strongly hit by HIV epidemic. And the fact that we ascribe to them a series of features, traits, characteristics, make them an easy target for violence, mistreatment, marginalization. In Latin America and the Caribbean, it is estimated that every week, every single week, 8 to 20 transgender or gay man is assassinated. And this is an expression of ignorance, fear. Fear of what? People fear that a gay man can make advances, a gay man can transmit infections, a gay man can recruit other people to his orientation, all type of stupid things that are based only on ignorance, pure ignorance. So as it was commented before, education is a basic element to counter these type of reactions. Another element which is present in this phenomenon is the closet. People who remain inside the closet feel protected, feel safe. They don't come out because stigma and discrimination will have an impact on them. But this has a side effect. We cannot see the humanness of gay men. We cannot see the humanness of a transgender population, of men who have sex with men, of bisexual men. And we have, therefore, a vicious circle that perpetuates the problem. We don't know them. They don't show their face. They don't demonstrate to us that they feel fear, love, suffer exactly like any other human being. So staying in the closet is a protective element for individuals, but it's detrimental for the reduction of stigma. So we have to create a climate more conducive for people to express their wholeness, including sexual orientation, sexual identities, sexual attractions, gender identities, and gender and sexual behaviors openly. The prevalence of HIV infection among MSM is 4 to 20% in Latin America and the Caribbean. This is well above the prevalence we find among general male population, which is around 0.5% in the United States, for example, to 1% in the Caribbean. Look at this, 4 to 20% is 40-fold the prevalence we find among general male population. Carlos Cáceres, who is an investigator with the University Cayetano Heredia in Lima, Peru, conducted an interesting study and found that the more repressive the legislation about homosexuality, about sodomy, the sodomy laws, more strict, the higher the prevalence. So there seems to be a correlation between repression, pushing people into the closet, and risk and vulnerability to HIV. The prevalence among male to female transgender people is 30 to 34%. This means that this population is the most highly hit by HIV infection and other sexually transmitted infections. Think about the social position and social value of transgender women, who usually have been evicted from their houses, have been denied access to educational processes, have to live on the streets, usually use drugs to have the strength and courage to make a living through sex work. So it's not surprising that these individuals have higher rates of infections. Calling them drivers of the epidemic is a misnomer, is a stigma. The same way that we try to refer to infected children as innocent victims. We don't have drivers and we don't have innocent victims. We have people living with HIV, with the infection, that acquired it through different routes, means, but all of them have this common element, and we have to really display all our resources to support them in this reality. One reality about gay men is, and other men who have sex with men, is that about 1/2 of them don't know their status, and don't know their status because they don't want to come out and look for a test. It's tremendously threatening to come to a service and admit, I am gay, I have had high-risk practices, therefore I want a test. Consistent condom use among MSM is low to moderate, and I took as an example one country in the region, Nicaragua, in which of the MSM interviewed in a survey, only 19% said that they use condoms in a consistent and systematic manner. This means that in spite of all the information we have, there is a lack of I heard in the previous presentation this morning, a lack of transfer of knowledge to action. Applied knowledge is power, and they lack the power to apply the knowledge they have. Why they don't have the power? It could be related to multiple factors. One of them could be low self-esteem, among many others, related again to stigma and discrimination. Less than 5% of the resources devoted to deal with the HIV epidemic in the region are devoted to prevention among MSM or other groups like female sex workers, like drug users, like transgender people. This means that there is still a discriminatory, a biased attitude, even in the investment of resources. I'm going to skip some of the transparencies I have. I have a lot of information, but I want to make reference to some of the factors that are related to the transmission of the HIV virus. And as you can see in the square on the left upper side, stigma and discrimination play a critical role. Not only the fact of having sex without protection, having an STI or a high viral load, but also the elements that prevent me of, in a very empowered manner, take control over my health, my sexuality, and my life. Thank you very much. So, what we need to do in terms of specific actions, I have already mentioned education, critical, and academic and educational institutions should play a role in normalizing diversity. And I'm talking now about ethnic, age diversity, sexual diversity, all types of diversity. This is critical. Another element is legislation. Legislation should be revised in order to prevent punitive laws, eliminate punitive laws that are based on misconceptions and medieval ideas. People who have attraction for persons of the same sex are as productive, as beneficial to the society as any other person. So these type of legislations are highly detrimental to public health. So I'm not talking as a human rights advocate in this moment, I'm talking as a public health officer, and these legislations cause harm to public health, and they should be revised and removed. And norms, we need norms applied in healthcare services, norms of zero tolerance to intolerance, zero tolerance to stigma, to mistreatment, to violation of human rights. We need those norms in educational institutions, zero tolerance to homophobic bullying, zero tolerance to transphobic bullying because they cause damage. Imagine the pain and suffering that a kid or an adolescent who is continuously tortured by bullies has to endure, and the impact that will have on her life for the rest of her days. So policies, legislation, norms are essential elements in the constellation of actions that need to be undertaken. I'm going to finalize my presentation making explicit reference to what we are doing in PAHO, the Pan American Health Organization. We are putting a special accent on promotion of sexual health. Why on promotion of sexual health? Number one, because sexuality is a critical component of our lives and should be incorporated to our lives in a healthy and gratifying manner. I was a little bit horrified, and let me express my surprise when I heard some young people talking in the previous presentation, expressing what to my ears sounded a little bit of fear of sex. We should embrace sex as part of our lives. It's wonderful. It's part of the condition of being human. We should embrace it, but with responsibility, with knowledge, and leave it in a a full manner, but without causing damage to ourselves and without casualties. That's the important thing about sexuality. The second element why we embrace this agenda, it's because sexuality is strongly associated with a heavy burden of disease in the region. In fact, the highest burden of disease in the world is associated to sexual behavior. Did you know that? Think about the HIV/AIDS epidemic, STIs, cervical cancer, unwanted pregnancies, maternal mortality, breast cancer, prostate cancer. All these things have to do with sexual health. And when you add all of them, they constitute the highest element of burden of disease worldwide. Why are we not addressing these things? Because we live in a society which is hypocrite about the need of addressing sexual health in a comprehensive manner. We cannot afford that anymore. We cannot continue prescribing behaviors. We cannot continue hiding parts of sexuality. We cannot use sexuality anymore as the boogeyman to scare young people. We have to address sexuality in a healthy and objective manner. So, in our regional agenda, we make the following recommendations. Number one, to bring back the S of sexual and reproductive health, sex, sexual and reproductive health, but without forsaking the R. The reproduction is important as well. Link programs by breaking tubular structures. So try to ensure that we don't talk about HIV in a way that it's separated from other important elements like tuberculosis, like STIs, like mother and child health. We need to ensure that the problems of the epidemics are mainstreamed. We need to tend to the needs of all through the life course, of all, absolutely all. Not to separate individuals in terms of their belonging to majorities or minorities. Focus on prevention by addressing determinants of health and reducing vulnerabilities, especially those linked to stigma and discrimination. Provision of comprehensive services that see people as biological, psychological, and social units, not as diseased organs. Reduction in inequities to access, and prioritizing the most at-risk populations. So the final message I want to leave this afternoon with you is that if we want to deal with stigma in a serious manner, we need to think about sexuality. We need to think about education. Therefore, we need to think about comprehensive sexuality education for all through the life course. And we need to think about provision of care for sexual health. And sexual health understood not only as the events related to reproduction, but including them as well. Thank you very much.
I want to thank everyone for coming and sticking with us. I think this was a great conference. I love the fact that we've gotten even better than last year. So, Dr. Anna, thank you very much.
Well, thank you, Lisa. And you know what I would like us to do? I mean, I really would be repeating myself if I start giving another lecture. I think we should all stand up and clap for the organizing committee. Please stand up. And let's give them a hand for doing an outstanding job. I'm not going to name everybody. So many of you have participated in the organization process. And thank you, Lisa, and good God bless. I actually am inspired, and I actually am more inspired than I was last year. So somebody made very crucial comment, where do we go from here? And that's important issue. But the person who said that, I hope she's still here. 4 years or 3 years ago, one of our medical student group who deals with HIV education, they were calling the churches. And this young lady said, Dr. Rana, I called these 7 or 8 churches, and I wanted to come talk about HIV and sexuality. And they say, oh, no, we don't have anybody with HIV in our parish, so that's not a thing we would like to talk about. So from then to now, we have come a long way. That we had a session full of pastors, deacons, and people of faith, and that session had close to 200 individuals who stuck it out. That session, they had to stop the question because there was a line of questioners. So people had a lot to say. And one of the things which is very critical is repeated over and over, that stigma, plain and simple, is ignorance. Okay. And if you look at Aaron and Lisa wanted to have our slogan, let's wipe the stigma virus away. It was very appropriate that stigma is a virus. Stigma is a virus which infects our brain, and it totally kills compassion, mercy, empathy. It stops them from working. If it was a computer virus, that would probably be even better example. Virus alert, worm alert, that, oh, you can't operate Microsoft Word anymore. Why? Because it has virus. You can't open this file. No compassion file found. Why? There's a virus. There's a worm. There's spyware. So I think stigma, treating it like a virus, is a good idea. But one of the things Imam Johari, who was one of the speakers there, talked about was a couple of lines from Quran, where Quran totally talks about all the bad habits of Arabs, all their taboos, all their ignorances, and all the bad habits they are into. And one of the verses Imam Johari quoted is the verse where God is telling that there is no harm on you or the person who has a disease to eat together. There's no harm on handicapped to eat with you in your house or on the same table. And remember how Arabs have always eaten, and they eat the same way. It took my wife and I a little while to learn to eat like this, because they eat from the same plate. So there was some wisdom that at that time leprosy was there, at time tuberculosis was there, but as long as you wash your hand, there's no harm in eating with your hand and from the same plate. So that was light. The chapter is called Light. If anybody wants it, it's online. You can go look at verse 56, 57. That destigma, and that's why this is so good, isn't it awesome? Light. So and having talked about Quran, I think it's so important. Jesus said, let your light so shine. What do we take home from here? Let your light shine before men and women so that they can see your good work. Okay. Catch yourself when that stigma virus starts showing up. Catch yourself. I think biggest responsibility we have is me, myself. Let me make sure I'm not spreading stigma. Let me make sure. And checking. Then at the family level, and then at the community level. And tell, you made such a beautiful comment. The minute you hear an ignorant comment, it's okay to look righteous, stand up or hold your hand. Hold the hand of your brother. You can't say that. I have a friend who is like that, and my kids do it to me. My wife does it to me, and I think it's perfectly okay to do it. So I think that's the best example. And then certainly at the community level and ultra-structure level, working at legal level to change policies and other things and to speak up. I think web is a wonderful side. I think the whole idea last year was let's create a narrative for people with HIV, because we didn't have a narrative. I think we have come a long way, even within a year or two. White House for the first time recognized stigma as a word related to HIV after David Millett came here and he took it back. And I think we have to thank. So you guys deserve a lot of credit. And Dr. Mazin, I really appreciate your contribution. You've been a source of inspiration for us. And your talk today was masterful. Thank you. So I just say this, I don't know if it's going to work or not, but even a tiny flame, maybe that won't work and that won't work, but maybe this would work and maybe that won't even work, because this is an old computer. But the idea of all these was that it's all about shining a little light, and we lighted a little flame. Let's keep it burning. Thank you so much, and God bless you all.